Good afternoon. Welcome to Her Dignity Network's webinar on evidence-based best practices to address maternal mortality with Dr. Monique Chireau. My name is Paige Cunningham, and I'm the Executive Director of the Center for Bioethics and Human Dignity. The webinar today is part of our initiative in global women's health and an 18-month campaign on maternal mortality. This is our final webinar in a series of 4. Previously, we examined projects to reduce maternal and infant mortality in Kenya, Nicaragua, and India. But today, we will tie things together from a global perspective. It is my pleasure to introduce Dr. Monique Chireau. She is the Assistant Professor of Obstetrics and Gynecology in the Division of Clinical and Epidemiologic Research for the Department of Obstetrics and Gynecology at Duke University Medical Center. Dr. Chireau is also a research associate for the Center for Health Services in Primary Care. Dr. Chireau has broad research interests, including genetic epidemiology in women's health, adverse pregnancy outcomes, women veterans' health, and racial disparities in women's health. Well, Dr. Chireau doesn't spend all her time in the ivory tower. She continues her practice as a staff gynecologist at the Durham VA Medical Center. How does she have time to do it all? We also count Monique as a friend. She spoke at a foundational meeting that led to the establishment of Her Dignity Network and was a plenary speaker at the 2012 Summer Conference sponsored by the Center for Bioethics and Human Dignity. You may have connected with us through Her Dignity Network. The network is the online vehicle for our initiative in global women's health, and the website address is there on your screen. Her Dignity Network connects people and organizations from around the world who share 2 basic ideas: that women's dignity is human dignity, and also that the bodies and health of women and girls matter. It matters to their human dignity and our common humanity. And no woman or girl should be discriminated against or exploited just because she's female, whether she is a widow in India, an unborn girl in China, or a woman with disabilities in Kenya. And that's what Her Dignity Network intends to change. We want to protect all of her health for all of her life. One way you can get connected is to follow us on social media. In fact, we would love it if you tweet or post during the webinar. Hashtag HDNWebinar, hashtag maternal mortality, or the Facebook page is Her Dignity Network. And we invite you to become a member and join the network. And guess what? It's free. Join the network. And this slide will appear again at the end of the webinar. Before we begin our presentation, I want to invite you to write down any questions as they come to mind. Because of the nature of the technology, you won't be able to enter them until the end of Dr. Chireau's presentation. So you have to have those ready to go so you can be first in line. And then we will try to get to as many questions as possible at the end of our Dr. Chireau's presentations. And of course, we will pass along all your questions to Dr. Chireau. Your questions are actually valuable to her as a researcher and helping her in better research and better communication and education. But enough for me. Now let's hear from Dr. Chireau.
Yes, hi, this is Dr. Monique Chireau. It's an honor to be with you here today. Thank you for the wonderful introduction. And today we're going to discuss evidence-based best practices to reduce maternal mortality. I'd like to express my appreciation to Her Dignity Network for inviting me to speak. I would also like to make the disclaimer that I do not receive any compensation from any commercial entity. So just starting off, why is maternal health important? And I like this picture because it's reminding us that women are important. This is reason number 1. Women are important. Maternal mortality is not an abstract concept. These are women who were actually waiting to see me at my women's health clinic in Nepal back in 2012, and they are the faces of hope. However, consider that they would be at risk for dying in childbirth if they became pregnant. And this is a tragedy because the role of the mother in the family, community, and society cannot be overestimated. Mothers are an integral part of the fabric that holds societies together. The second reason is that children are 100% of the future. I heard a pediatrician say that once, and that was a very powerful statement. We're not minimizing the importance of maternal health, women's health. Obviously, we are here because we believe in the dignity of women, but the lives of women and children are inextricably connected. High maternal mortality correlates with high child mortality. The third reason why maternal mortality is important is that it's an indicator of population health and well-being. This is true in both developing and developed countries. Decreases in the maternal mortality rate are part of the obstetric and demographic transition. Now, maternal mortality is sensitive to issues as we were discussing earlier, the status of women, access to clean water and sanitation, social disruption. And there is something called the obstetric transition. It's a theoretical model which has only recently been described, which basically identifies a process moving from high maternal mortality, where there is no intervention to change the natural history of complicated childbirth, to low maternal mortality. Now, of course, there's considerable debate about how this process can be facilitated, and that's beyond the scope of the talk today. But let's look at some evidence. So recently, there's been a great deal of discussion regarding, excuse me, rates of maternal mortality and what they mean. Up until about 2011, 2012, there was a widespread perception that progress in maternal mortality was lagging behind other key health indicators. Data were cited to suggest maternal mortality rates were high and not decreasing, and there were numerous articles stating that a major cause of maternal mortality was unsafe abortion, and that many deaths were due to restrictions. New data suggests, however, that these perceptions and assumptions are incorrect. In fact, it appears that maternal mortality not only is decreasing worldwide, it's decreasing rapidly, and that unsafe abortion is not a leading cause of maternal death. So what does this mean? Let's look at really what was a landmark study that was published in 2010 or 2011. It was a very, very large study of maternal mortality using World Health Organization data for 181 countries over the period of 1980 to 2008. It was a systematic analysis of progress toward Millennium Development Goal number 5, and I really won't get into that in great detail. The MDGs, the Millennium Development Goals, are specific goals that are set up by the World Health Organization and the World Bank to try to track and promote international development. And so in this study, what the authors did was use some fairly sophisticated statistical techniques to begin to analyze data on a number of health indicators, including maternal mortality. This two studies were published, one in 2010, one in 2012, and this really fundamentally reset thinking on maternal mortality. Why is that? In the first place, what it showed was that traditionally there's been a view that human birth rates are skyrocketing, populations out of control. If you look at this particular graph, let me break this graph down. What you see is these different intervals on the graph recommend swaths of populations, regional swaths of populations. For example, this blue area is Southeast Asia and India. This area down here is East Asia. So these are huge numbers of births, millions and millions of births. And what you can see is that over this period from 1990 to 2008, the birth rate has been steadily declining and plateauing. That's the first observation. The second is that if you look at maternal deaths over the same period of time, what you see is that maternal deaths are dropping actually at a rather steep rate. This is across all regions of the world, especially in the regions that have high percentages of births. Now, I'm just going to take a quick sort of sidestep here. Traditional thinking in epidemiology and demography is that where you have high fertility, high birth rates, you have high rates of maternal death. And this is showing that that is not necessarily true. This is a world map, a heat map. Some of you may be familiar with heat map terminology. The red areas are areas of highest maternal mortality. You'll notice that Afghanistan stands out, parts of Central Africa stand out as being countries and regions where rates of maternal death are high, whereas the dark blue areas are where maternal deaths are lower. And navy blue is the lowest rate, and so on. But if you look at the decline in maternal mortality rate, you see that it's fastest in some countries with high birth rates. And I think that this is showing that the impact of skilled birth attendants or trained birth attendants in prenatal care is greater than the impact of each woman having many pregnancies. Again, that's not something, it's a fascinating subject, but I do want to move on to actual best practices. So if you exclude, again, this is just pointing out how one particular factor can have tremendous impact. If you exclude maternal mortality due to HIV, you see that the rates of annualized decline in the maternal mortality rate are actually even better than they looked in the previous slide. It's noteworthy also that half of all maternal deaths are concentrated in 6 countries: India, Nigeria, Pakistan, Afghanistan, Ethiopia, and the Democratic Republic of Congo. However, India has shown one of the fastest declines in maternal mortality. Maternal deaths in Afghanistan accounted for almost 6% of all global maternal mortality, even though there were less than 1% of births. So why is maternal mortality continuing to drop worldwide? There are a variety of different reasons. Increasing education, because there's a powerful correlation between education of girls and women and reductions in maternal mortality. Increasing income, possibly smaller families, that's not clear because, again, as we saw, in some regions where women prefer to have larger families, rates of maternal mortality are still dropping rapidly. And then, of course, improvements in birth care are probably one of the major reasons. Now, in response to the two studies by the Hogan Group at the University of Washington, the Institute of Health Metrics, the World Health Organization released revised estimates of maternal mortality, which were lower than their previous estimates. In addition, they began to work on a series of large multi-country follow-up epidemiologic studies that were published earlier this year in a special issue of the British Journal of OBGYN. The study that we're going to look at today is from March 2014, and it's called Maternal and Perinatal Morbidity and Mortality, Findings from the World Health Organization Multi-Country Study Survey. One of the most important outcomes of the study was to provide estimates of the percent of maternal deaths that were due to major causes, such as postpartum bleeding or hemorrhage, hypertension in pregnancy, and so on. This is a list of the countries that were involved in the the multi-country study. As you can see, it's a fairly wide distribution from nations that have lower human development indices to higher human development indices. Just having a little trouble scrolling down here. All right, we've got it. Now, in this particular slide, which is adapted from their data, what you can see is that the leading cause of maternal death is postpartum hemorrhage. This makes sense. This is, whoa. And a number of countries were included in this study. Let's look at the slide which describes their exact results. And this is showing that the two of the leading causes of maternal death are postpartum hemorrhage and high blood pressure in pregnancy. Interestingly enough, the indirect causes of severe maternal outcomes, such as anemia, infection, malaria, and HIV, considered in aggregate, are actually very important causes of maternal mortality. What I'm saying is that while it is more common for women to die from postpartum hemorrhage or high blood pressure in pregnancy, if you look at the somewhat less common causes, these are referred to as indirect causes. In other words, they contribute to the mother's death through other mechanisms than actual mortality. But they add up to be extremely important in affecting the overall maternal mortality. Some other very interesting findings from the study were that abortion, spontaneous and induced, was not an important cause of maternal mortality. This was because in the study, and I'm quoting from page 29 of the study, it is not possible to distinguish between miscarriage and abortions in this sample. So let's look at these top causes of maternal mortality one by one. Number one, as we noted, was postpartum hemorrhage. Number two was high blood pressure in pregnancy, anemia, infection, and so on. Now, in this study, 27 women died from complications of spontaneous or induced abortion. I do want to clarify the terminology. So spontaneous abortion is a miscarriage. Gynecologists refer to all early pregnancy losses before approximately 5 months gestation as being abortions. They're either spontaneous or induced. Spontaneous meaning that they happen on their own, and induced meaning that through mechanical or other means the pregnancy was terminated. Now, it's rather remarkable that in a study of this size, which was over 400,000 women, a relatively small number of women died from either spontaneous or induced abortion. Number two, that the authors were not able to distinguish between the two. Partly this has to do with how miscarriages and abortions are classified. However, what's most clear coming out of the state is that one cannot state, based on the World Health Organization's best data, that induced abortion is one of the most important contributors to maternal mortality. This is significant. Why? Because to effectively address maternal mortality, we have to address its most common causes. Now let's look at some best practices walking through the spectrum of causes of maternal mortality. We've seen the evidence from various studies. We have a very clear idea of what the most common causes of mortality are. Now let's apply that evidence to identifying best practices. So clearly, postpartum hemorrhage is the #1 killer of women, and actually that's true in the United States and developing countries as well. The first task is to provide skilled, and I would actually add trained birth attendants. There's been a lot of controversy in the literature over about the last 30 years as to whether to use trained birth attendants or just traditional birth attendants. And it appears that birth attendants, midwives really do need training. The first point is to use uterotonics. And what uterotonics are drugs that make the uterus contract after birth to reduce bleeding. This includes oxytocin, which is preferred only because it's somewhat more effective. However, you have to give it by vein or in muscle, intramuscular administration. That's a problem in low-resource settings where syringes, clean syringes, are not available. Oxytocin also is not that stable in heat. And so recently, misoprostol is an oral agent that has been used. There's, of course, some controversy with its use, but it's being evaluated in head-to-head trials with oxytocin as to whether it's effective. And it is effective in helping to control postpartum hemorrhage. Its main advantage is that it's oral. The second most common cause is high blood pressure in pregnancy. Again, providing skilled and trained birth attendants. One of the best ways to determine whether a woman is going to develop high blood pressure in pregnancy, and this is one of my research interests, is to identify them early and to refer them to try to deliver in a more structured setting, if at all possible. However, the nature of hypertension in pregnancy, or preeclampsia as it's called, is that it is extremely unpredictable. So the #1 way to address that is to give a drug called magnesium sulfate. Now, in an earlier slide, what's very noteworthy is, let me see if I can pull up that slide here. In this study, it's rather impressive that 95% of the women in this study received some kind of uterotonic. In other words, they received oxytocin or misoprostol. And 40 to 100% received magnesium sulfate. That's very impressive because, as you saw, many of the countries in this study are low-resource settings. And so the evidence is being put into practice. Women are being given these life-saving medications. And, of course, another consideration, which is often very difficult, is that women with high blood pressure during pregnancy are at risk for developing high blood pressure after pregnancy. Anemia is a very significant cause of maternal mortality, even though it's an indirect cause, because women who are anemic are not only who are anemic during pregnancy are not only less able to tolerate the blood loss that occurs with delivery, resulting in their death with a postpartum hemorrhage, but they're also more vulnerable to infections and heart failure. And so there are different ways that this can be addressed. In settings where you don't have the ability to analyze blood to see what a woman's blood count is, you can quickly and easily look at the inside of her eyelids or the palms of her hands. Iron is inexpensive, it's an effective treatment. Encouraging women to eat a nutritious diet is not quite as easy as it sounds. It's because in many cultures there are very strict rules, cultural rules and taboos about what pregnant women can and cannot eat. And then finally, it's important to identify and treat causes of anemia. Malaria is probably the #1 cause, closely followed by worms, malnutrition, kidney disease. Infection, possibly including HIV. Now, the authors of this study probably were not able to clearly delineate between different types of infection. Most commonly in obstetrics, we tend to think about infections in the immediate postpartum period. Prenatal care can help identify those, and we'll discuss HIV as being a very special subset of infections. But one of the most important things is to be able to identify an infection and treat it. Tetanus vaccination is extremely important. Tetanus is still a major killer of women in the postpartum period and infants. And during childbirth, trained birth attendants should use clean technique. For example, if they're using birth cloths, they should iron those birth cloths. If they're using instruments, those instruments should be boiled for 5 minutes to 10 minutes before the birth happens. And then, of course, quickly identify and treat severe infections that occur soon after giving birth. The what are called postpartum infections used to be a major cause of maternal mortality in the United States up until the advent of antibiotic treatment. Malaria and dengue, malaria and dengue, malaria is one of the leading causes of infectious disease death worldwide. And so identifying women with malaria and treating them while they're pregnant is very important. One of the issues with malaria is that if a woman has it, she does appear to be able to pass some sort of resistance to her baby transplacentally. But the recommendation is to diagnose women with malaria and treat them. There's really not an effective treatment for dengue other than supportive treatment, and then to observe for complications of malaria such as anemia and to treat those. Prenatal care can be very successful in identifying women who have malaria. Now, lung disease in this study was not very carefully defined, so it's not really clear whether they're referring to tuberculosis, measles, or pneumonia. Given the worldwide incidence and prevalence of tuberculosis and high rates of mortality, especially in developing countries, this was probably a leading suspect. We can vaccinate for measles. We can identify women with TB and treat. This is especially important because TB is a wasting disease, and especially in countries where there are high rates of HIV, the interaction between TB infection and HIV can be very severe. TB also has a number of very important long-term severe complications such as bone infection, brain infection, and so on. Now, I mentioned that we would talk a little bit about HIV. HIV is one of the most difficult problems to overcome. Even in developed nations like the United States, it is not always easy, but it's extremely important. Identifying women with HIV and treating them is an important goal that has largely been neglected in many settings as part of prenatal care and maternal care. This is because therapy is very expensive. It's difficult to administer. Many of these drugs need to be given multiple times daily. They have many side effects, some of which are quite severe. And so HIV treatment has not necessarily been prioritized in many maternal child health programs. That is different from the case of the use of antiretroviral drugs to prevent transmission of HIV during childbirth from the mother to the child. So there's excellent documentation to show that you can reduce the risk of transmission from about 29 to 30% down to less than 7% with treatment during labor. But that doesn't do anything for these women who are chronically infected with HIV. So it's one of the clearest problems that are out there, but certainly one of the most intractable problems in terms of reducing maternal mortality. Now, liver disease, again, is difficult to treat once it's established. And it has multiple causes. And both the issue of liver disease and HIV bring up an important question. Access to care implies access to diagnosis. So when we speak about being able to care for women, we have to think about, plan how to give them access to diagnosis. If these more indirect causes of maternal mortality are important, many of them are infectious, their thought has to be given to how to diagnose them. Liver disease is an example. You can diagnose the fact that the woman has liver disease, but diagnosing the cause is sometimes challenging. And so one of the long-term strategies for reducing the prevalence of liver disease in populations worldwide is hepatitis B vaccination. And heart disease is also in this category. Heart disease is easy to recognize. Rheumatic heart disease, which results from women and men who are infected with strep. That's why we all worry about strep throat, that untreated strep can eventually cause damage to heart valves, resulting in what's called rheumatic heart disease. These are tough to treat. And tuberculosis is also an important cause of heart disease, as are parasitic infections. A subset of heart disease is caused by anemia, where women, especially when they're pregnant with the increased demands of the baby, find it difficult if they're extremely anemic. Their heart cannot pump enough blood to keep them perfused, and so they may develop heart failure as a result. In those cases, treating their anemia will often resolve their heart failure, provided it hasn't gone on for too long. And then finally, let's review abortion. Again, as we've noted in that study, if you looked at the fact that abortion, a certain percentage of the abortions that were listed as causes of maternal mortality were due to miscarriage, and another proportion were due to induced abortion. If you just did a quick sort of back of the envelope calculation, that would make abortion number 10 as the cause of maternal mortality in this study. And again, the way to address this is to treat miscarriage appropriately and to reduce induced abortion. Again, induced abortion is an elective procedure, and whereas, of course, miscarriage is not. This is a little Sudanese girl, again, just reminding us that women and children's health are completely intertwined. Most cases of maternal mortality result in the death of the fetus or newborn, and because we care deeply about the dignity and sanctity of women and their children, reducing maternal mortality improves the lives and health of women and their children, like this little girl. I do want to spend just a few minutes here discussing maternal education. It's not necessarily intuitive that low maternal education is a risk factor for maternal mortality, but numerous studies have shown that it's one of the most powerful risk factors for maternal mortality. This is important because while a health system may not be able to identify and treat every cause of postpartum hemorrhage or every woman with HIV or liver disease or heart disease, education is something that can be made a national priority that can have a tremendous impact on maternal mortality. Now, the reasons why this is true are not exactly clear. It appears that one theory is that women who are educated are better able to identify potential situations where they need intervention or engagement with the health system in order to prevent a bad outcome. Another is that women who are better educated are better nourished. They tend to live under more sanitary conditions. They tend to have lower death from infection and other common causes of mortality. So one of the first large studies back in 2012 by Koch et al. From Chile found that women's education was one of the most powerful predictors of risk for maternal mortality. In addition, excuse me, as part of this World Health Organization multi-country cross-sectional survey, Cunningham and his group found that maternal mortality among women with the lowest education level was more than 5 times greater than for women with the highest level of education. And what was most interesting in this study was that whether a country was moderate income country or lower income country or higher income country, this relationship persisted, showing that in the arena of maternal mortality, education trumps income. And that's a very interesting perspective because, again, we might not necessarily think that educating women would result necessarily in improvements in maternal mortality, but now there's quite a bit of data to show that that's the case. And what that does then is education is clearly a priority in many countries. Education of women not necessarily a priority, but it clearly shows that intersectoral efforts, in other words, collaborative efforts between the public health, medical, and education sectors can result in great gains for populations. So I'd just like to summarize, start summarizing at this point what we found. It's important to focus on the major causes of maternal mortality because resources are usually, and I should cross that out and say, always limited. We cannot focus on addressing every potential cause of maternal mortality in countries where, for example, I've been in meetings with the Ministry of Health where they've said, we have a choice. We can either screen and treat for HIV or we can vaccinate children. Which do we do? That's pretty stark. That just puts everything right out on the table. What are our choices going to be? And this is where the role of non-government organizations coming alongside ministries of health can really focus on specific populations. But resources are always limited. I don't know, I know very few situations, unless you're an NBA basketball star, where you have unlimited resources and can do whatever you like with them. So we need to prioritize and address the major causes of maternal mortality. This is good stewardship, it's efficient, and we can continue to look at direct and indirect causes. As I noted earlier, we want to prioritize women's education. We only want to use proven interventions. There are quite a few of them out there. I mentioned just a couple, using oxytocin and misoprostol for postpartum hemorrhage, using magnesium sulfate for treating high blood pressure and seizures in pregnancy, using antibiotics to treat infections. And I would also like to add that it's extremely important to improve the quality of data collection. Why? Because the issues that I might see in South Sudan are going to be quite different from the issues in Nepal. But Nepal is at altitude. Altitude increases the risk for high blood pressure in pregnancy, increases the risk for anemia. In Sudan, there might be a higher population prevalence of HIV, vitamin D deficiency, and hypothyroidism due to goiter are going to be pretty low in Sudan, are going to be higher in Nepal. And so you can't fight what you don't see. If individual ministries of health, NGOs, and so on and so forth are not collecting adequate data, we can provide sort of the global view, but the onus is on people working in individual nations, locales, working with specific people groups to identify what the areas are. For example, in South Sudan, where we're going to be working hopefully in the spring, Kala-azar or visceral leishmaniasis is a very, very important parasitic infection, which is extremely common. Not knowing about the effects of Kala-azar, how to treat it, how to diagnose it, you're doing a disservice to the population of people that you're trying to help. Now, I do want to put in an encouragement. Some of those statistics we looked at earlier about the coverage for giving uterotonics, drugs to reduce bleeding after childbirth, the coverage for giving magnesium sulfate to treat hypertension in pregnancy are remarkably high, considering the incredible challenges that are facing trained birth attendants, midwives, and physicians in many developing countries. It shows that people are working very, very hard. And that is reflected in the fact that with some notable exceptions, such as Afghanistan, maternal mortality is falling worldwide. And I often show a picture, I didn't get a chance to take this picture, of a pair of earrings that I got when I was in Nepal. Well, why earrings? It's not just because I'm vain. These earrings are very interesting because they're made from local materials. And one part of them is this kind of blue glassy material. And I remember when I bought them, I said, oh, that's interesting. The more I looked at them, I realized that the artisan, the jeweler who made them out of a Koch bottle, where they ground the glass from the Coke bottle into the shape that they wanted for the earring, then attached some goat hair and a piece of carnelian to the earring. What that person was doing was using what they had. And that's one of the major encouragements that I try to give, and sort of the exhortations to people thinking about and working in this field. Use what you have. The picture of how individual ministries of health, non-government organizations, clinics, hospitals, health posts is going to address their issue of maternal mortality with the woman in front of them is going to look different from the way I address it in the United States or in any other country. But by using what you have to develop sustainable approaches that are evidence-based, we can continue to have this significant impact on the maternal mortality and continuing to reduce it. So another encouragement from the Hogan study that I cited earlier, and I'm quoting, our assessment suggests that we should be optimistic about our ability to improve maternal mortality. The dramatic progress occurring in some countries should be closely examined to learn how these successes could be replicated. It's my contention that these successes not only can be replicated, but will be replicated by dedicated people who are doing their best to preserve women's lives, and that's in the context of recognizing the individual dignity of every woman, every human being, and the sanctity of life. I'm going to leave you with this picture by Marc Chagall. It's called Maternité, and this is what we're all after. We may not want to have the donkey there with the dove there, but a healthy mom and a healthy baby. That's our goal. Thank you very much.
Thank you so much, Dr. Chireau, for, wow, a lot of really good data there. This is now your chance to enter your questions in the question bar there on your screen. And I'd like to just start with one question, and that is, this is incredibly encouraging how we've seen this decline in maternal mortality. So how would you respond to someone who would say, we're doing well here, we're on track, it's coming down? Is there still urgency? We've got Ebola, we have other crises. I mean, how would you, as someone who's interested in public health, respond to a comment like that?
Well, I think that's a good question. And there are two pieces to that. One is that in public health is sort of, one definition is a series of competing priorities. So there are always competing priorities for money, time, workforce, and so on and so forth. What I would say to that is to be very careful, because the improvements in maternal mortality, decreases in maternal mortality, have been coming, but they can slow or reverse. We saw this very clearly actually in the 1970s and the 1980s with the sort of worldwide recession and problems where ministries of health just did not have money. And what happened was that starting in the late 40s and early, actually probably more like the mid-1950s, there was a sustained push to reduce infant mortality. That was what you heard all the time back in the 80s, reducing infant mortality. There was a lot of dedication, a lot of funding, a lot of people were trained in epidemiology, and amazing responses, or amazing reductions in infant mortality were seen to occur. That reversed in the 1980s and 1990s. So we have to be careful when people say that, well, you know, we've got this under control. Maternal mortality does not go away. We can eradicate polio, we can you know, try to eradicate tuberculosis, but for the human race to continue to exist, women have to continue to give birth. And I think that that's where the idea of the obstetric transition comes in, that as we address these preventable causes, as populations become better nourished and so on and so forth, you do reach a tipping point where maternal mortality begins to drop precipitously and then remain low. But in many of these countries, we're not there yet.
Thank you. Our next question is, what is the most significant impediment at this point to making improvement in this area from your perspective?
I think there are two impediments. Number one is the training of birth attendants, and number two, it's the availability and the diffusion of the appropriate technology to the people that need it. Those are the major challenges. Now, just as an example, some NGOs have come up with a birth kit, which those of you who've actually given birth or been present at a birth may remember. It's kind of a sterile pack that has scissors and a cord clamp and some iodine and so on and so forth. Getting those into the hands of the people that need them is very challenging, but people are using creative approaches. They are stocking them in small towns. They're selling them at large discounts to individual women in different families. Those, I think, are the two greatest. I don't think it's necessarily a policy issue, because I don't know that policy or political will alone is going to solve this. I think it's a question of training and diffusion of technology.
Thank you. The next question is, you mentioned that education had a greater impact on reducing mortality because it does contribute to smaller families. Does that mean that we should not focus on family planning and spacing of children as a way to reduce maternal mortality?
Yeah, if I gave that impression, I think that's not what I meant to say. What I meant to say is that and the study in Chile was quite revealing, as societies go through the demographic transition, women's education increases, many women choose to begin to limit the size of their families. My personal feeling is that women and families should have as many children as they want to have. I don't believe that the emphasis on family planning is, I think the emphasis on family planning is problematic in that if a woman is dying of postpartum hemorrhage, we really need to devote our resources to addressing that issue. I'm not saying that family planning is bad and evil, but I am saying that in my experience over the last 20 to 30 years, there's a disproportionate emphasis on family planning as opposed to simple, easily utilized interventions that could reduce maternal mortality.
All right, thank you. I just, again, want to remind you, if you do want to ask a question, you will have time to do that. So if you can just go ahead and enter those in, we'll be glad to take those. I have one more question waiting here in the queue, and that is, you mentioned maternal mortality in the United States. I thought we had resolved that. How does that differ from maternal mortality outside the United States that you described?
That's an excellent question. So one of the things that has happened recently, which has us as OBGYNs and public health people really pulling our hair, is that maternal mortality is beginning to increase in the United States. There are a variety of reasons. Some of it is what we call detection bias, where we are looking more carefully at, in other words, the data collection has improved. Above and beyond that, though, what's happening is that other causes, indirect causes of maternal mortality, for example, in North Carolina, where I am, motor vehicle accident is one of the leading causes of maternal mortality. Because women in the United States are experiencing a shift in the age at which they first become pregnant, many women are becoming pregnant in their late 30s and 40s. At the same time, with rising rates of obesity and chronic disease, there's a collision between the age at which women choose to become pregnant and the incidence and prevalence of chronic disease. So what I mean to say by that is that women are becoming pregnant as they also are becoming diabetic or hypertensive. And this is leading to a great deal of maternal morbidity and mortality because hypertension is a significant risk factor for poor maternal outcome. Obesity is a significant risk factor. Diabetes is a significant risk factor. So what's happened, and again, this is kind of the far side of the obstetric transition, is that in the United States, maternal mortality remained high actually until the institution of hospital-based births and sort of the introduction of sterile technique and so on in the late 1800s. After that, maternal mortality dropped pretty significantly up until the 1940s with the advent of blood and antibiotics, and that came out of sort of military-related technology from World War II. So then the maternal mortality rate continued to drop and only recently is increasing, again, because of chronic disease and also the effect of HIV. So we are not, like I said, we're on the far side of the demographic transition in the United States, but we're facing a different set of problems where our maternal mortality rates are beginning to increase. And it's mostly because of chronic disease.
Wow, what a different set of factors. Who would have thought about car accidents being so relevant to maternal mortality in the U.S.? We do have a question from one of our participants who is asking if your slides would be available after the presentation. I guess they're probably, you had some wonderful material and data there. And if you are willing to do that, we can figure out a way to share that with them.
Mm-hmm. That's fun.
All right, we will follow up with the participants. And someone else has shared a resource on U.S. maternal mortality, which we can also, excuse me, make available to the participants. As we're finishing up our questions, I just wanted to mention two things. The next two slides you will see on your screen will be how you can participate in the network, how you can join in what we're doing here in focusing education and resources on issues of health affecting women and girls. And then the final slide will be a reminder about social media. Another question has come in. Dr. Chireau, can you see a role for pregnancy resource centers as part of the solution to education?
Now, when they say pregnancy resource centers, just
like to deal with crisis pregnancy that provide assistance to women who are already pregnant. Do you see that as part of the education that's needed, whether inside the U.S. or outside?
I think definitely. I think outside the U.S. It would be extremely powerful because very often in developing countries, number one, the stigma of having a crisis pregnancy is very powerful. The Pregnancy Resource Center provides an opportunity for those women to not just get help, but to become more educated about pregnancy, about their bodies, so on and so forth. And they can then function as advocates in their communities. They can even go on to be trained, for example, as trained birth attendants or village health workers or whatever. So yes, I definitely see an opportunity for that. In the United States, of course, we're at a different point in the demographic transition. But again, I think that the Pregnancy Resource Centers provide a unique opportunity for women to begin to see pregnancy and childbirth as not pathologic, but as a means of reinforcing to women, or sometimes even introducing to the concept of the dignity and sanctity of life. So yes, I definitely see that. I see a somewhat different role with different implications outside the United States, but equally important, I think.
Thank you. We do have another question. Now this is moving a little bit to a different role, your educational role. How do you incorporate this information into your courses as you teach?
Well, I think that's a good question. So I'm not currently teaching a course on maternal mortality at this moment. When I do teach on maternal mortality, I think that my goal is to present the data as it is and to say this is what the data seem to be saying. At that point, if people have a difference of opinion about it, it's a data issue. You're choosing to agree or disagree with the data. You may not agree with what I'm saying about it, but here it is. You can look at it for yourself. And so I think that the key is to present a balanced view of what data say about maternal mortality and its causes, because a lot of people coming up into public health and into maternal and child health and medicine have only heard certain viewpoints regarding what the important causes of maternal mortality are. And so the key is just to take the perspective that this is the best quality data that we have and present it as such.
Thank you. We have another question that has come in. What most encourages you despite the challenges in terms of the progress? So let me actually rephrase that. You know, what's encouraging you? We see many challenges and we see progress. What do you find most encouraging in all of that?
Well, it's very interesting because when you're out in the field, when you're out in Nepal or India or South Sudan, the Philippines, wherever you are, it can be overwhelming. It can be really overwhelming. What is encouraging to me is two things. Number one, the heart that I see in the people who are on the ground, the people who have a woman in front of them that they have to make a clinical decision about. They are so motivated and so interested in learning, and they want to know, how do I make things better? That's a major source of encouragement, because very often in these settings, women come in, patients come in, and they're so far gone, there's really nothing you can do. They have been in labor for days, the baby is dead, they have been bleeding, and despite your best efforts, they die, they expire. So as terrible as that is, you focus on the person, not just the person in front of you, but the healthcare worker, or even the public policy person, or the epidemiologist that's there, and looking at the difference that making just a few changes, a few simple changes, training people to use consistent cleanliness, vaccinating for tetanus, treating for malaria. You focus on a few interventions that you know can make a big difference. And one of the most encouraging things to me personally is to look at some of those graphs and tables where you see the decline. People are out there working as hard as they can to try to do something about this problem. And that's what you have to encourage yourself with, is that people want to do their best despite the issues and problems that their governments have, and that we can help them to do that by coming alongside of them. So that's what I find most encouraging.
Well, thank you, Dr. Chireau. I have just a brief announcement, but I wanted to just thank you for what you are doing on the front lines of research and education, and for those who have have joined us. And one of the things that you can do in the network is pray, and we will just continue to pray for you because you are speaking in places that many of us don't have the opportunity to interact. And we're just grateful for all that you do. I wanted to mention to our participants that you will be receiving a brief survey about the webinar, and your feedback is very helpful to us and very important to us. We do make our webinars available online after the webinar, and so in the weeks ahead you should look for that as well. So this is a useful resource that you can refer back to. You can refer back to Dr. Chireau's explanation of the slides as well. But I just thank you all for joining us today. I invite you to join the network. If you go on the website, you can see how our friends are expanding around the world, and we'd love to see you add your name to the list and get your dot on our global map. And again, thank you all for being with us, and we look forward to the next webinar. We'll be starting a new series, and now that you are on our list, we will be giving you information about that for our next Her Dignity Network webinar series. Thank you.